Hello, my name is Millie Long. I'm at University of North Carolina at Chapel Hill, where I'm a gastroenterologist in the Inflammatory Bowel Disease Center. I had the pleasure of presenting at a symposium called Reaching Beyond Anti-TNFs for the Therapy of Ulcerative Colitis with Miguel Reguero from Cleveland Clinic and with Bruce Sands from Mount Sinai. And together we talked about some changing paradigms in the treatment of ulcerative colitis. And I think first and foremost, we have to figure out better ways to identify which patients are at risk for more aggressive disease. And so one of the things we talked about was emphasizing that it's not just what the patient's symptoms are now, but whether they also have risk factors for more aggressive disease. And also we need to take into account individual characteristics of that patient's past treatment history in defining what would be best for that patient. And so I'll give you an example. A patient may be having 5 to 6 bowel movements a day with intermittent blood. Does not sound that severe, but if you take into account the fact that the patient has required prior corticosteroids, is very young, had deep ulcerations on past colonoscopy, those are risk factors that this patient has more aggressive disease, potentially even than the symptoms they're mounting at this moment. So when you take into account all of these factors, I would argue that instead of looking at disease activity, we're looking at disease severity to help to guide how we treat those individual patients. And we used a couple of patient examples in the symposium. And we talked about what various classes of medications are available. I think most gastroenterologists are well versed in the treatment of anti-TNFs for moderate to severe ulcerative colitis. This has been a mainstay of therapy for some time. We have 3 in that field. We use infliximab, we use adalimumab, and we use golimumab. But certainly we now have newer agents that allow us, in those patients who don't respond to those therapies, or perhaps, obviously these therapies are also approved for first-line use in individuals with moderate to severe ulcerative colitis. There are scenarios where we might use these ahead of the anti-TNF. And so let me talk about 2 of the newer classes of medications. The first is the JAK inhibitors. And the first one we have to market is tofacitinib. This was approved just this past summer for the treatment of ulcerative colitis. And it's a small molecule. Because of that, it's actually also oral, which is nice for our patients. And it seems to, in the Octave studies, which brought this therapy to market, it really seems to work pretty quickly, which is another nice aspect where in some instances we may be able to avoid some of the corticosteroid use for induction. And the therapy itself also doesn't have immunogenicity. And so this is nice in that we would not use this in combination with another therapy. So there are no immunomodulators that we would use. There are a few safety signals with this drug that we do want to take into consideration. One of the things we reviewed at the symposium is kind of a treatment management algorithm when you are initiating someone on tofacitinib. So we'll talk a little bit about that. One of the things that you can see with tofacitinib is you do see an increase in lipid profile after initiation. But interestingly, it's both the HDL and the LDL that go up. And so often this doesn't necessarily confer additional cardiovascular risk. The recommendation is to check a lipid panel at 8 weeks and then to use cardiology standard guidelines to help us to know whether to start the patient on an anti-lipid agent. The other aspect to this therapy is there can be some infectious risks. And the one that we're seeing with more frequency is actually herpes zoster or shingles. And now shingles has been seen in association with multiple other agents as well. For example, we've published data that show an increased risk, particularly with corticosteroids, also with azathioprine and with the anti-TNF agents. But we certainly see this signal with tofacitinib as well, and it does seem to be somewhat dose dependent. So the higher dose of tofacitinib, the 10 milligrams twice daily that we use for induction, we use that over the first 8 weeks, actually is associated with somewhat higher risk of herpes zoster as compared to the 5 milligrams twice daily, which we can then back down to for maintenance. And so with this in mind, I always counsel patients about this risk. And certainly the nice thing is that we do have a vaccination now. We actually fielded a good number of questions during the symposium about that vaccination. There's some shortages now, but hopefully that will be overcome soon. But this is an inactivated vaccine against herpes zoster that actually has much greater efficacy than the previously available live vaccine. So we have a vaccine that's not live, can be given to patients on immunosuppression, and is more efficacious. It's given in a 2 vaccine cycle. You give it at time 0, and then you give it again anywhere from 2 to 6 months later. And so in my practice, I try to give that first dose when I'm making the decision to start the tofacitinib, and then subsequently follow them up per the appropriate time interval. Now, this vaccine is only approved in the general population for those aged 50 and older. So I'm giving it to all patients aged 50 and older, but certainly in those individuals younger than that whom I'm starting on tofacitinib, I am having a risk-benefit discussion about whether or not this vaccine is something they may want to receive at a younger age. At this point, it may not be covered by insurance at that point, so it's something definitely to discuss with the patient, but something that we can consider given this risk profile that we've seen. And so again, an infectious risk, but certainly something that could be preventable with appropriate vaccination techniques. The other interesting aspect to this herpes zoster risk is it does seem to be more prevalent in Asian populations. And so certainly in Asian populations with that higher risk, even in younger age groups, I'm really discussing this vaccine. Other monitoring, we certainly do monitor CBC, liver function tests, just like we do with many of the other agents. And if someone has severe anemia or significant hepatic dysfunction, tofacitinib is likely not the right drug for them. And we screen out those individuals, and this drug can be used, again, in both first line, but also in this beyond anti-TNF, after TNFs have failed scenario. And so one of the things we also discussed was kind of some indirect evidence from a network meta-analysis. And this network meta-analysis helped us try to compare therapies across studies. As you know, unfortunately, we don't have head-to-head comparison effectiveness randomized controlled trials really in Crohn's disease or in ulcerative colitis. The one exception to that is in UC, the UC Success trial. And that trial looked at infliximab as compared to azathioprine, as compared to both infliximab and azathioprine. And what that trial showed is that the combination with infliximab and azathioprine actually had higher rates of mucosal healing as well as clinical remission. And so this is something that I do commonly in my practice. But that's it. We don't have other comparisons in terms of head-to-head randomized controlled trials. And so therefore, this recent network meta-analysis used the indirect evidence from the clinical trials to help us to try to make some of these comparisons. And in this comparison, in terms of efficacy, there are efficacy and safety outcomes. Certainly, efficacy, it did seem that anti-TNF was quite good. Other agents, including tofacitinib and vedolizumab, subsequently. And then in the anti-TNF failure population, it actually seemed that tofacitinib came out on top. One of the things that's interesting in a lot of the data we see in both Crohn's disease and ulcerative colitis is that with the biologics, after that first biologic, the second biologic seems to have a diminished response. And so this may be one reason why switching to a small molecule could be something you could consider. Other classes beyond TNF, vedolizumab. So this is a great therapy in terms of safety. It also does well from an efficacy standpoint, but really it shines from a safety perspective. It's a gut-specific medicine, so it targets alpha-4 beta-7. It's an anti-integrin therapy. It's given via infusion at weeks 0, 2, and 6 for induction, and then every 8 weeks. And vedolizumab, we have more and more data in terms of both real-world data, reanalyses from some of the clinical trials, the Gemini studies that brought this therapy to market. We've been using it since about 2014, and really since that time have demonstrated excellent safety signals. Because of its gut specificity, we have not seen malignancy risks. We have not seen infectious risks. There was some concern initially in the clinical trials because it was an anti-integrin. Would there be a risk of PML, progressive multifocal leukoencephalopathy, a brain infection? And actually, that has not been the case whatsoever. Natalizumab, its cousin drug in Crohn's disease, has been associated with PML. In use in ulcerative colitis, there has been one case of PML, but this was a patient with HIV who also was on significant immunosuppression, and the case was actually thought to be related to that and not to the underlying vedolizumab. And so from an efficacy standpoint, again, randomized controlled trial data, superiority over placebo, good efficacy in a similar range to the TNFs and other therapies. And so this therapy also can be used either first line or second line. And there are specific subpopulations that we talked about where I would really consider this drug first line. So for example, an older patient where you're concerned about malignancy or infection risk, vedolizumab might be a great choice in that population. Other examples, a patient who, again, safety being the priority, is most interested if they had had a prior malignancy themselves. This is someone that we want to potentially try to avoid systemic immunosuppression and take advantage of the gut specificity. And so this is an agent, again, beyond anti-TNFs that we can use for both induction and maintenance of remission in ulcerative colitis. One of the other things we talked about at the symposium is some new data that were just presented at the ACG meeting just actually about 2 months ago in Philadelphia. And my colleague Bruce Sands, who actually chaired this symposium, was the one who presented the initial induction data for ustekinumab. So as you know, ustekinumab is actually approved for the treatment of Crohn's disease. It's an initial IV infusion with a weight-based strategy. And then after that, subsequently, it's 80 milligrams subcutaneously every 8 weeks for maintenance. And so, again, it was approved in 2016 from a Crohn's disease perspective. We have a good experience with it for that. But these are the first data showing efficacy in ulcerative colitis. We don't have the maintenance data out yet, but again, the induction data looked quite good, similar to other medications. And this will be an excellent option for our patients as well. Ustekinumab also seemed to have good safety signals from the data, not only in the Crohn's disease and ulcerative colitis development data. The safety profile was quite similar to placebo. We did not see infectious risks, malignant risks, but also importantly, the PSOLAR registry, which is a psoriasis registry for ustekinumab, which has been approved in psoriasis for some time, has shown no significant safety signals associated with this therapy. So yet again, providing us with another option for the treatment of ulcerative colitis. And so now that we have this whole arsenal, we really are trying to target based on the individual's clinical scenario in terms of their symptoms, their risk factors for progressive disease, and considering specific factors surrounding the individual. For example, if someone had significant extraintestinal manifestations, they had a bad psoriasis potentially associated with inflammatory bowel disease, I might use an anti-TNF or once it's approved for ulcerative colitis, ustekinumab, because I'm looking more systemically to control that inflammation. So we talked about a lot of those types of scenarios. One of the other things that came out in the case discussion was we talked about a case, a patient who progressed, as I know you all have seen in your practices and I have seen in mine, from mild to moderate to then severe hospitalized ulcerative colitis. And once that patient hits severe hospitalized ulcerative colitis, they have a very high risk, of course, of going to colectomy. So we talked about strategies where we could optimize therapy for them in that specific population of acute severe ulcerative colitis. And so in those individuals, they come in, we do a flexible sigmoidoscopy, they're quite inflamed, their CRP is quite high. We initially initiate IV corticosteroids, and in those individuals who don't respond, we really need to think about another agent to help to induce and then potentially maintain remission. So we talked about two options here. You can use infliximab or you can use cyclosporin, a calcineurin inhibitor. And the cyclosporin has been around a long time. But importantly, we now have a couple of more recent studies that have really showed non-inferiority to infliximab. And so this remains a viable option in terms of treating the acute severe ulcerative colitis patient. However, it's a little bit difficult and wieldy because there's a lot of laboratory monitoring, there's some contraindications, and cyclosporin really should only be used for induction. You then need to move on to a different agent for maintenance. Most often, azathioprine, for example, for maintenance of moderate to severe ulcerative colitis. However, the case I presented actually had already been on azathioprine, so we knew that would not be a good exit strategy. The patient had already failed azathioprine, and so we used infliximab. But one of the important considerations about using infliximab for acute severe ulcerative colitis is that there are scenarios where that patient may completely waste that drug in their stool, actually, meaning they aren't going to maintain appropriate therapeutic levels that will hopefully help treat the inflammation and reduce their need for colectomy. And so there are some factors that are associated with kind of increased clearance of the infliximab. And in those individuals, we likely need to increase the dose and shorten the interval to be able to maintain an effective level. So what are those factors? So interestingly enough, males, people who have a higher BMI. And one of the things I really look for is people who have a low albumin. In those low albumin patients who really have pancolitis that's quite significant, what's been found is that the drug, initially their level goes up and then they lose drug in their stool, and so they're not able to maintain an appropriate level. And so we talked about some retrospective data that have been published that have looked at an intensified dosing algorithm for the treatment of ulcerative colitis, where you're using more frequent infusions. We also talked about some survey data that show that gastroenterologists are also using higher doses of infliximab, again, to just try to maintain that level. And interestingly, in the retrospective data, it really showed a marked difference at prevention of colectomy at 3 months in terms of using this accelerated dosing regimen as compared to the standard dosing regimen. And so how do you operationalize that in your practice? Well, I'll tell you what I do in my practice. Again, this is based off of retrospective data. We don't have randomized controlled trial level data. But even the long-term follow-up, this is a way that we can hopefully help to save some of these colons. That said, an important aspect of any algorithm of treatment of acute severe ulcerative colitis is involvement of the colorectal surgeons. And I really do that right away, kind of when that patient is put on steroids, so that they can help to follow with you, help to find the indications for medications have failed and now it's time to proceed to surgery. And so with collaboration with the colorectal surgeons, in appropriate scenarios, I will dose intensify the infliximab. And so with this, what we do is we monitor the CRP, that really hot inflamed patient with a high CRP. You give them a dose of infliximab. In my practice, I'll often give 10 milligrams per kilograms as that initial dose. And then you monitor their CRP. And when that CRP starts to plateau again, and again, initially it often goes really quite down, starts to plateau, that's often a proxy for that drug level really getting quite low in their system. And then you dose again. And that accelerated regimen that I discussed may actually help to prevent colectomy, at least over the short term, over that 3-month interval. And so we talked about these kind of optimization strategies for that severe UC patient. Again, emphasizing that cyclosporin is a good alternative, but you just have to think about your exit strategy associated with that therapy, since it's not a good maintenance therapy. So again, over the course of this symposium, we walked through what are the agents beyond anti-TNFs that we can use for treatment of moderate to severe ulcerative colitis. We talked about the fact that we need a new definition of disease severity that takes into account a lot of these prognostic factors, not just disease activity, but really using disease severity. And then we talked about tailoring those therapies towards specific factors in subpopulations, using those clinical characteristics with the patients to use in a shared decision-making fashion the ability to come up with a plan that is effective for that patient. And so really these data hopefully will be helpful to you in your practice. We certainly enjoyed the symposium and hope that you did as well. Thank you.